Well, hello everyone. Welcome to TPOT Gastro. And at this point, you should have a pretty good idea as to what we're about. And as we continue gaining interest, then you guys will start enrolling, and we'll end up having a virtual classroom dealing with medical education. But before we do that, well, you know the routine. You can go to www.indusintellect.com. And this time, however, you will then click on the tab of Gastroenterology, and then there, lo and behold, will be a question for your very satisfaction. But this time, when you then go ahead and answer the question, I'll then issue a certificate in which you can then accumulate as you get more and more of your correct answers, so that at some point in time, if you so desire, then those certifications always come in handy. Once again, you may then go to my website, take a look at the question, and you'll have the necessary information. Now, today, dealing with integrated gastroenterology, we'll begin by looking at that question. And with that question, it's the fact that we have this time a 32-year-old male that comes in with long-term issues with swallowing. The patient explains that for the past 3 years, he's been feeling like he always gets food stuck in his chest when he swallows. The recent bout of such an incident during lunch finally made him decide to come pay a visit to the doctor. Past medical history reveals use of over-the-counter antacids and proton pump inhibitors. However, he does state that these meds have been minimally effective. He also takes netoglenide and metformin for his type 2 diabetes and combo therapy of budesonide and formoterol for asthma. Now, due to the swelling here, the upper endoscopy is then showing you the observation. And the question is, which of the following patterns of disease behavior would most likely be expected in this patient? Now, remember, I'm going to walk you through the answer choices, but in terms of full explanation, as we continue building up the bank of questions and information, and as you continue enrolling, then we can talk about more about what you're seeing. So I can't give you that information now. A, distoesophageal would reveal a segment of ganglionic degeneration. Histologic remission of eosinophilic infiltration after proton pump inhibitor therapy. Inflammation, predominantly of eosinophil mediated of greater than 15 high power field or HbF. Intestinal metaplasia of the esophageal squamous epithelium. And upper endoscopy reveal engorgement of superficial veins of the esophageal mucosa. And as we've been doing, we're now going to move over to the video, but this time I'm going to do things a little bit differently so that you understand how to, once again, remember the videos, or in general, even if it's been a few weeks or months or perhaps even a year or so, need to make sure that we update it constantly, don't we? And with that said, here's a video with an algorithm dealing with dysphagia. Our patient, remember, was having dysphagia for 3 years. Now, without going into crazy detail, but I want you to get an idea as to things that we're doing here. And remember, we're going to go through all the specialties that are important for you on your boards. And before we begin, let me play the video here.
We'll be looking at an algorithm. And with the algorithm, as I told you earlier, the objective of this slide is to show you the behavior of the dysphagia. If it's solid food...
All right, now we're not going to spend time, and we just are not going to spend the time to go through all 10 minutes or so of the video, but I want you to get a firm handle as to what this algorithm is, and you can still very much use it throughout all of your boards, and then also into your internship. Dysphagia here, remember, this is swallowing, but the big picture, and this is something that we would discuss in class, is that if you have an individual that just had a meal, let's say it's most commonly, let it be turkey, let it be beef, or let it be chicken, and then immediately after eating, there was this unbelievable expectoration of saliva. There was inability to swallow on a sudden onset. Remember, our patient in this scenario was having issues with dysphagia for 3 years. So no way in the world would you even categorize that as being acute. So that was a non-acute type of dysphagia. This algorithm here that you're going to be seeing is all that of non-acute type of dysphagia. Because acute dysphagia will not have issues such as scleroderma or esophageal rings or achalasia or even that of esophageal cancer, correct? All of that will be non-acute. Granted, some of those dysphagia, especially of esophageal cancer, does move in a rapid manner. I'll give you that, but we're talking about immediate expectoration of saliva, maybe perhaps coughing and such. So that chicken or beef or turkey commonly in the US that might then get impacted is then causing acute type of dysphagia. And of course, the management at that point is remove the darn blockage, right? And so that could be either piece on meal or on block, whatever, through an endoscopic grasping tool, and that'll take care of the acute. Now, apart from that, there's going to be a lot more discussion and warranted for non-acute type of dysphagia. Now, the two big categories that you're going to be looking at here, and then constant updates here, is the fact over to the left we have solid foods only. If you're suspecting solid food non-acute type of dysphagia, then please understand that the issue most likely is going to be mechanical. And then after mechanical, then you're going to categorize that as being, well, was it progressive or was it indeed intermittent? So if it is solids only. Now, could liquids be involved? Sure. For example, if you did have a mechanical obstruction in an elderly patient in which there was iron deficiency, maybe due to blood loss and then weight loss in an elderly patient, well, initially there were solids that were not getting through. And then, let's say months down the road, the liquids also were affected. But it began as solids. So that would be mechanical. And there, your number one differential in that patient, no doubt, would have to be esophageal cancers, correct? Or what if it was intermittent? And if it's intermittent, and that's what this is trying to show you here, is that we're dealing with esophageal rings. Now, a piece of information that I need to give to you here in a second is the following. So far, our topic brings us to what's known as dysphagia, right? Next, under dysphagia, we then took that and we branched that into two issues. We talked about acute, which is not the algorithm that we're looking at, or non-acute. This non-acute issue that we're seeing here is the topic that we're looking at, isn't it? That algorithm on top. Under non-acute, what you'll do next is then divide this into, well, was my issue dealing with solids? That's probably not a very good color, so let's start that over again. Was it solids? Or, and if it was solids, then the issue that you're looking at, for the most part, is going to be mechanical in issue. And I don't have time to go through all of them, but what I'm trying to show you next, that if it is mechanical, then the next set of questions you're asking yourself, was it progressive? Doctor's handwriting as usual, and or was it intermittent? I'm giving an example as to what you can expect. Now, you would be in class, and with my horrible handwriting, you would be taking down your notes, no doubt. And we'll talk about how that may occur on in due time. But at this point, we're laying down the foundation. Things are getting more and more interesting, aren't they? So under mechanical, we're talking about non-acute, obviously, type of dysphagia, and we have progressive, we have intermittent. Under intermittent, interesting enough, well, you're going to ask this question. Now, before we even do that, what kind of dysphagia are we dealing with here in non-acute? What do you mean, what kind of dysphagia? Remember, what if the patient had issues with botulinum? Maybe it was syphilis. Maybe it was Lyme disease. Maybe it was dermatomyositis or polymyositis. Maybe it was drugs, in which the issue that took place was coughing, choking, and nasal regurgitation. That's your first question that you're asking. What did I say? Coughing, choking, nasal type of regurgitation. Well, think about that for 1 second. Where would that non-acute type of dysphagia be taking place? Remember, our topic now is non-acute. Well, that type of dysphagia with nasal regurgitation and coughing and choking would have to be oropharyngeal type of non-acute dysphagia. Is that clear? And those are the type of updates that are now expected of you when you take your boards for 2019 moving into 2020. Once you rule that out, then all the issues that we're looking at here is not that of oropharyngeal dysphagia. Our patient, remember, our patient felt as though that after swallowing that meal, recurrently over 3 years, it felt as though that something was stuck in the chest. Something being stuck in the chest would not be a blockage taking place in the oropharyngeal region, then it would be something of the esophageal dysphagia. And that's what this entire algorithm is dealing with. It's dealing with esophageal, non-acute type of dysphagia. Next, it was the fact that began with solids here, and then under solids, you will know that you're dealing with mechanical obstruction. And then you ask yourself, is it intermittent, or you would ask yourself, it was progressive. Under intermittent, meaning to say that it was coming and going, and perhaps there was no issues with liquids. So it's definitely mechanical. And then now at this point, look at the differential in the video. You'll notice that we're talking about rings. Or what if the patient did indeed have, what if it was a child, had issues with asthma, maybe had dermatitis, atopic type of issue? As soon as you start thinking about type 1 hypersensitivity, then you're thinking about eosinophils, and that's a major update that we have to make. Because please note that a mechanical obstruction of the non-acute of the esophagus, in which it's intermittent type, in which the patient has issues with allergies, maybe it was a child's atopic. Remember, our patient was taking medications. Notice that the patient was taking antacids and proton pump inhibitors. Remember, once again, you can go to the website and take a look at the questions so that you can see exactly what I'm referring to. Well, the patient said that it was minimally ineffective, right? Because it wasn't issues with GERD. If it was GERD, then yeah, you could have dysphagia perhaps. But then the proton pump inhibitor, you would definitely find some type of relief. But in this patient, that wasn't the case. What else was the patient taking? Oh, it was a combination of, remember, you've heard of Simcort, and that is a combination of your formoterol or buzinamide, in other words, a corticosteroid and a beta-2 agonist for asthma. And so therefore now you should be thinking along the lines of eosinophilic type of esophagitis, which unfortunately is on the rise in the U.S. and something that needs to be updated for you. Now, with that said, and that's what
only that the patient is suffering or experiencing dysphagia too. What kind of differential, what kind of description would you then call it? Let's talk about intermittent at first.
Okay, so here's a video that goes on to talk about the various types. Now, if it was solids and liquids, then you start thinking about not so much mechanical, but then you start thinking about motor type of issues. If it was intermittent, well, let me show you something that you're going to find to be quite interesting. Okay. Now, quickly here, we're going to end the little session here just to quickly go through some images and such. Let it be barium swallow or upper endoscopy of all the important differentials that you must know for your boards before you start walking into the wards. Now, what you're seeing that looks like a corkscrew on your far left over there would then be your diffuse esophageal spasms. So there on barium swallow, it looks like a corkscrew, doesn't it? That perhaps you would put into the wall while you're putting up a painting, what have you. And you can expect the manometry there to be all over the place, and that would be a discussion that we would have. And that obviously is dealing with motor issues, isn't it? If it's motor, then you're thinking about solids and liquids. The patient's going to have difficulty with swallowing both solids and liquids. Start thinking about motor. Whereas our discussion earlier in the video that I was showing you, it began as solids only. And if it was solids only, and we talk about intermittent, then you're thinking about esophageal rings. You know about, well, which one of these is a ring? Well, if you take a look at the bottom portion here and on to your far left at the barium swallow, if you take a look at the distal port of the esophagus, and then up on upper endoscopy, the picture in the middle here in the bottom is a Schatzky ring. A Schatzky ring is located usually and commonly in the distal esophagus. And the patient here is going to have issues with what kind of foods? Solids only, which means that what kind of dysphagia is this? Non-acute esophageal dysphagia, and it's the fact that this is going to be intermittent. These are Schatzky rings. Barium swallow on the left, And then in the middle here is obviously upper endoscopy. Then over to the far right, what if instead of a ring, the patient had issues with mechanical obstruction of solids? It was intermittent, but this time also was accompanied by iron deficiency. And then you start thinking about esophageal webs. And what do you know about esophageal webs? They tend to be in the proximal portion of the esophagus, usually post-cricoid, correct? And there, once again, you would have mechanical obstruction. But those are fair game. You must be able to identify what they look like. So we did the corkscrew. Then in the middle, on the top there, does that look like a bird's beak? That would be achalasia. Now, if it was achalasia, then there, once again, remember, it's the issue in which embryologically you may not be able to migrate your neural crest cells into the mesenteric plexus, or lack of mesenteric plexus, called that aganglionic. Sounds quite similar to the pathogenesis of Hirschsprung, doesn't it? But this time we're up in the esophagus. So if you don't even have the mesenteric plexus, that's motility, isn't it? It's motility. And there would be progressive solids in liquids. Achalasia is in the middle. That's your bird's beak. And then on the top, on the far right, our patient in the scenario. Now, that upper